Hello.
Okay.
Raja, I am audible. No.
Good evening, sir. Am I audible?
Loud and clear, Rohan.
Great. Thank you.
I am audible.
Yes, Dr. Samaria,
Yes.
audible.
Yes,
Hello.
Hi,
Hello.
Dr.
Yes,
Jindal.
sir.
Hello, hi.
कैसे हैं
Hi,
आप?
Dr.
I'm audible too, I hope.
Absolutely loud and clear, Dr. Jindal. Loud and clear.
Thank you.
So, Rohan, I have recorded my talk.
Yes, sir.
So, once Dr. Jindal finishes and my talk starts, I'll disappear for a few minutes and then come back again. Okay?
Right.
Is it the same platform for the audience?
I suppose yes, because 27 people have
Yeah,
joined.
correct. Correct. So, yeah, okay.
Good evening, sir. Dr. Bera, sir.
Good evening, good evening.
Dr. Samaria.
Good evening.
Good evening.
नमस्कार सर.
नमस्कार, कैसे हैं?
बस ठीक है.
Good.
Good evening, Dr. Behra. Namaskar.
Good evening, Raja. Good evening. Good evening.
So can we start or we'll just wait for 5 more minutes? Hello?
Yeah, we can wait for some 2-3 minutes.
Okay, sure.
Dr. Dhar, let us know if we can start.
5 minutes. Huh? How many?
Okay.
Got 36 people. So I think in 5 minutes we'll have about 50, which is a fair number to start off with. So let's start in
यहाँ से
5 minutes.
वीडियो
Okay.
मेरी नहीं वो दिख रही है। यहाँ से तो नहीं वो यहाँ से कौन सा
Dr. Behra, good evening, sir.
Good
Good
evening.
evening, Rohan.
Good evening, sir. Good evening.
Good evening, everyone. Dr. Jindal, Dr. Samaria, Dr. Dhar. So, Rohan, all yours. Whenever
Yes,
you
sir.
want to think about,
We'll start in 2 minutes.
all yours, and you and Dr. Dhar.
Hi, Dr. Kumar Prabhash. Good to see you.
Good evening.
Dr. Dhar, shall we start? Sir, I think we lost you for a moment, but I think we'll start.
I said we are good to go, Rohan.
Great. Good evening, one and all. I welcome you all to the scientific program on smoking cessation in lung cancer. Along with Dr. Kumar Prabhash, under the guidance of Dr. Kumar Prabhash, and also with support of Dr. Rajadhar, I welcome you all, and I would like to introduce our chairperson. We are very glad and to have our chairpersons, Dr. J.K. Sumaria and Dr. Arvind Krishnamurthy. Dr. Arvind Krishnamurthy was supposed to join, but due to last-minute emergency, he couldn't make it. But nevertheless, his blessings are there. But Dr. Sumaria is there with us, and we are very thankful for him to give his time. I will just give you introduction about Dr. J.K. Sumaria. Dr. J.K. Sumaria sir is organizing chairman of NAPCON 2021 to be held in Varanasi from 31st March to 3rd April 2022. He is a treasurer of Indian Chess Society. He is an ex-professor and head of Department of Chess Diseases, Institute of Medical Sciences in BHU Varanasi. He is also the director and chief consultant Center for Research and Treatment of Allergy, Asthma, Bronchitis at Varanasi in Uttar Pradesh. So we are really glad to have you on this particular event. So without wasting any time, I would request you to proceed. Thank you, sir.
Thank you for nice introduction. I am audible.
Yes, sir.
So it is my pleasure. It is my pleasure to introduce and invite Professor S.K. Jindal as a first speaker. And he is a legend of respiratory medicine, legend and veteran in respiratory medicine in country for almost over. He's holding this position more than 20 years in the country. Sir, he is going to talk on the problem of smoking and non-smoking tobacco in India. Sir, Dr. Jindal, sir.
Thank you very much, Dr. Samaria, Professor Bera, Dr. Rajadhar, and other distinguished kind of people on the dais. Presently, of course, on the on the PC or phone, whatever you see you have. Well, it's my pleasure to talk on the problem of smoking in general. You see, at this symposium on lung cancer and smoking cessation. As far as so I will just. Can you see my slides?
Not yet, Dr. Jindal.
Not yet, sir.
Sorry.
We have a copy of your slides, sir. Can we share it from our side?
I think that maybe that is better option. I think.
Yeah. Yeah. Can you see your presentation, sir? Dr. Jindal?
Yes. No, not yet. I can't see you. See the presentation.
I can see the presentation, Dr. Jindal.
Yeah, we can see it.
I think. Okay, I can see it now. I see.
Okay, sir.
Very much visible to us, to our audience.
Okay, is it okay? The problem of the question is why to focus on smoking or tobacco in general. In fact, because smoking is only one component of tobacco with which we are generally familiar, although the non-smoking forms of tobacco are equally important, especially for this oncology group. And we know that tobacco smoking is the leading cause of preventable illness and death, and accounts for enormous healthcare burden all over the country, and responsible for several types of cancers as well as non-communicable diseases, both cardiovascular as well as respiratory. We will not go into those details at present. Next, please. Of course, we all are familiar with the risks from smoking, and almost any organ can be involved from the head to the toes. You see, we are again not going into these details. I'll focus mostly on the burden of smoking in this country, the real problem. Next, please. Tobacco, of course, contains more than 4,000 chemicals, which are in one or the other way toxic for the body. Nicotine is one of the important component, but there are many other carcinogenic compounds, which again, almost 45 agents are carcinogens, you see, and over 400 of them are toxic and harmful agents. I think tobacco is perhaps the single most important carcinogenic compound, you see, in the world. Next, please. Another important issue is to know that tobacco is bad in any form or disguise, you see, because tobacco is smoked, and all of us are familiar. It is smoked in form of bidis, cigarettes, cigars, cheroots, chutta, reverse smoking. Professor Bera is very familiar in Odisha with these forms of smoking. Then there are other forms like hookah, hookleys, pipes, and chillums, etc. So that depending upon the region in which one lives, the type of smoking may vary. And same is true for the non-smoking forms of tobacco. Betel quid is the most common one, the pan, which we call. Then there are other different types of chewing tobacco or tobacco paste, the creamy snuff, the kind of, it's used in various forms, you see, called Manipuri, Mawa, Khani, and so on, you see. I think, but the fact is that it is either smoked or it is taken through the oral route, you see. Then there are various types of or exposures to this smoking. For example, there could be active smoking or the first-hand smoking, which is direct, or could be reverse smoking, like with chutta. Then there could be passive smoking or the second-hand smoking, and then we are also aware of the tertiary smoking from husband and others, to the smoking, I mean, smoking in front of a pregnant wife, the husband sitting there, you see, and that exposes or causes problems with the fetus in utero. So that is what we call as tertiary smoking. There may also be delayed exposure or the third-hand tobacco smoke exposure. The fact is that the degree of hazards or the degree of problems may vary, but all types of exposures to tobacco will cause one or the other problem to one or the other extent. Next, please. So what is the extent of tobacco use in India? It is on an average, India is home to 12% of world's smokers, or approximately 120 million. That is the WHO estimates, and more than 1 million die each year due to tobacco in India. Tobacco use, of course, is overall tobacco use in general. It is 267 million adults, or almost 30% of the population of the country, adult population of the country. Men, of course, it is more common, 42% of men, and women on an average it is 14%, although I'll come to the later kind of slide that it may vary from place to place. Smokeless tobacco, again, adults, of course, almost 21% of adults, and the smoking form is in 10.7% of adults. So one or the other kind of type of tobacco is used by the people in different regions. Next, please. It shows the prevalence of tobacco consumption by age and gender in India. And again, this is a kind of rough estimates based on estimates at a particular point of time. The numbers may vary, but the fact is that tobacco smoking in both, or the tobacco chewing, both are more common in males. The chewing forms are also increasingly common in females. In some regions in the country, females may in fact be even more than in males. Next, please. I think it shows the same kind of type of distribution of tobacco use among Indian women. Next, please. Tobacco use is not only seen in adults, but it is also common in children. And there was a study, the Global Youth Tobacco Survey, sometimes back, and it has been done all over the world, including in India. And the figures were rather kind of surprising, that 90% of children of less than 16 years age have used one or the other form of tobacco in the past. That is historically, means they may not be regular smokers, but certainly they had used tobacco, and 70% were still using at the time of the interviews. And in 13 to 15 year age groups, about 8.5% were currently using tobacco. The only implication or the kind of conclusion from this type of data can be that the habit starts very early in children, and many of the children have tasted one or the other form of tobacco. Next, please. Regional differences, as we were talking, that the highest rates in the country the higher rates are in the north as well as in the eastern parts of India, although no part is totally kind of averse or free from tobacco use. Certainly some areas like Punjab, for that matter, is one place where smoking is much less common, and whatever smoking is seen is generally seen in migrants or people from other states. And interestingly, this was also found that the highest rate of smokers in the country is in Kolkata. Dr. Rajadhar is here, and I think he will certify to this finding. 82% of men and about 23% of women were smoking, according to the survey of the International Institute for Population Sciences. And Uttarakhand, of course, are the highest region of BD smokers. Next. The prevalence of tobacco use by men in India, according to the National Family Health Survey 30, again shows the same types of findings, that there are regional differences, but practically it is common all over the country, certainly more in central parts, northern parts, and eastern parts of the country. And relatively, I think that the south is relatively spared. Next, please. Next. Yeah, sorry, next. Another important issue about which we talked was second-hand smoking, and almost 30% of adults exposed to second-hand smoking in indoor workplace, in restaurants and other kind of public places during transportation. So these types of exposures become more important when they are cumulative exposures. Otherwise, exposure may not be that critical, especially for diseases like cancers, lung cancer, or some other chronic diseases, except for acute effects of smoking, which are common. 20% of youth aged 13 to 15, according to the same GYETS survey, were exposed in enclosed public places, and even at home, 11%, which means the parents have been smoking in front of the children as well in several, in almost 11% homes. See. And the symptoms attributed to second-hand smoking, like respiratory symptoms, lung function impairment, chronic bronchitis, pneumonia, and poor asthma control, they are mostly acute symptoms, while chronic heart disease as well as lung cancer or COPD, they are more attributed to cumulative exposure. Next, please. BD smoking is also very common, and this is one kind of survey which, and the recent article, that there is a significant decline in BD smoking during the last decade, but still 71.8 million adults smoke BDs currently, you see. There are higher odds of BD smoking in males, older age groups, lower socioeconomic status, and of course it is compounded by other factors. Gap in knowledge, low price of BDs is also responsible, besides the culturally prevalent habit in a particular area. Next. Hookah smoking, quite common in the villages, in the older people aged more than 15 years of age, 50 years of age, than in younger people, and in rural areas, as I was mentioning earlier, with the relatively lower educational status. Next. Smoking-related mortality is very common. In fact, tobacco consumption is responsible for 1 in 5 of all male deaths, and in 1 in 20 of all female deaths in the country. This was the, of course, old data, but I think that stands true even today. And according to the Indian Heart Association, sometimes back, 1 million annual deaths from smoking were recorded or were estimated in 2010. India accounts for 83% of the world's heart disease burden. That was according to the Indian Heart Association study. Next, please. So this shows the overall all-cause mortality due to tobacco, 40 to 80% higher for any type of tobacco, 50 to 60% higher for smoking, and 90% higher for reverse smoking, and so on. See, an urban cohort study in Mumbai found the relative risk of dying was more than 50% for smokers and about 15% higher for smokeless tobacco users. Overall, smoking currently causes about 7 lakh deaths per year in India. Next, please. And the same is true for the economic cost to the society. The costs are huge, you see, according to 1718 estimates, it accounts for almost $27.5 billion in this country. And these costs are attributed to direct healthcare costs, indirect costs from loss of productivity due to illness and death, and cost of premature death, you see. In summary, the total cost of tobacco equate to 1.04% of India's GDP. I think that is a very high figure you can imagine here. And direct medical cost equate to 5.3% of total health expenditure, you see. So this is obviously because there are so many diseases which are related to tobacco, both non-communicable as well as the cancers, you see, that it is not surprising that this is a very high cost to the society. Next, please. So in summary, I will say that of course that there are changing trends these days, which we have found from data from several studies, that there are modest decreases in smoking prevalence, but that is in percentage. The absolute numbers of male smokers aged 50 to 70 years have increased substantially over the last 15 years. This is attributed to increase in the longevity, because the absolute numbers obviously would depend upon the total numbers and the number of adults which we are focusing at this moment. You see, smoking is increasing in women. That is another kind of concerning change. Cigarette smoking is displacing bidi smoking, and most notably among the young adult population, and even illiterate men now are opting more and more for cigarettes, you see, because of several factors. We will not go into those details. There is some decrease in the non-smoking forms, again, perhaps because of the overall, you can say, progress in the society, or the higher, the improving socio-economic standards, but certainly the non-smoking forms, the chewing, etc., remain very, very common. Tobacco control policies should adapt to these changes, most notably, I mean, that is, of course, the recommendation of the several associations and investigators, etc. Well, thank you very much for your patient listening.
Thank you, sir. Thank you very much, Dr. Jindal, for your nice explanation of the subject on this problem of smoking, non-smoking tobacco in the country. Now we move to the second talk of the day, and it's my pleasure to introduce and invite Dr. Rajadhar. He's a very close friend of mine, and one thing I want to tell about Dr. Rajadhar, that he is the heart and soul of our conference we are doing at our Varanasi in Nepal 2021 Varanasi. He is the heart and soul of that conference. He's working very hard for our conference. napalm. And presently, Dr. Rajadhar is the chair of the educational activities of the educational initiative of the Indian Chess Society, and he is the director and HOD of the Department of Pulmonology at CK Birla Hospital, Kolkata. Dr. Rajadhar, please.
Hello friends, my name is Dr. Rajadhar and I welcome all of you for this meeting on smoking cessation in lung cancer. I represent the Indian Chess Society and a very warm welcome to from the Indian Chess Society to all of you. To talk about tobacco use and impact on human health, and I will have some focus on lung health. We would also want to speak about how this is important, how this is relevant in the perspective of lung cancer. However, that would be done as a part of the panel discussion, which you will hear in a little while. So I start off by giving you some data. The most recent data we have is from the WHO fact sheet, and the data is startling. The fact that it kills up to half of its users, and we're talking here about tobacco in all its forms and not just smoking, and the fact that it kills more than 8 million people each year. If you think about other common diseases, heart disease, stroke, etc., you could add all of these common factors together and still have smoking superseding as a cause of mortality. The other startling fact which comes out from this WHO fact sheet is the fact that 80% of the world's 1.3 billion tobacco users live in low and middle income countries. And you understand that the impact on health, the impact on economy is going to be far greater in these low and middle income countries as compared to what it is in the Western world. So this is a two-way whammy. First, from the numbers fact and the mortality, and second, the fact that there's a bias towards the developing nations, towards the low and middle income countries, which makes it of even greater menace. When we talk about smoking, and you understand we're talking here about smoking rather than tobacco use, a question that needs to be answered is what qualifies as being a smoker? We would normally think it's someone who smokes daily. However, there might be others who smoke occasionally. They call themselves social smokers. Once or twice a week, they would say. Some would be ex-smokers, having stopped 5, 10 years ago. Some would say, previously I used to smoke socially, now I don't do that at all. And then there would be the never smokers. So out of 1 to 4, what qualifies as smoking? And probably the answer to that is any of them would qualify as smoking. But more importantly, you try and gauge and classify the varieties of smokers that you have. And this lovely paper, which came out in BMC Medical Information, tries to enlist and classify smokers depending on 2 factors. Whether they are ex-smokers or current smokers, whether their tobacco or cigarette consumption is less than 10 or more than 10, and when they take their first cigarette after waking up. And based on this, they classify these individuals as being light, medium, heavy, and very heavy smokers. I'll not read through this entire slide, but let's do light and very heavy smokers, just to give you a ballpark number as to how you classify these individuals. So a light smoker or an ex-light smoker is someone who has a tobacco consumption or a cigarette consumption of less than 10 cigarettes a day or equivalent, and over 60 minutes lapses before they take their first cigarette after waking up. So that's a light smoker. What about a very heavy smoker? A very heavy smoker is someone who's either a current very heavy smoker or an ex very heavy smoker who has tobacco consumption of 40 or more and who takes the first cigarette within 5 minutes of waking up. And medium and heavy smoker are classed in between. So remember these numbers, because when you're writing your prescription out, when you're advising your patient, it might be useful to classify them, A, to counsel them accordingly, and B, the treatment that you give, which will be discussed in great detail as we go along in this meeting, could be actually targeted according to the severity or the grade of smoking. Why do we talk about tobacco smoking so much? Why is it thought to be the greatest menace in the world? And the reason for that is that smoked tobacco seems to be the most addictive substance amongst all other drugs that's used. In this particular study, which came out in a journal of psychopharmacology, they looked at various addictive substances. And you can see on my pointer there, the substances that are mentioned here in our perception, at least in my perception, used to be far more addictive, far more dependence producing as compared to what cigarette is in my mind. So cannabis, cocaine, heroin are on that list. But look at the graph for prevalence of dependence in tobacco. That's the blue line. And you can see that 25 and beyond that, the dependence plateaus off. There's no waning. And that's why the tobacco addiction is thought to be the most potent, the most dependence producing addictions of all. If you look at things like psychedelics, for instance, or heroin, for instance, there's a downward trend, there's a downward graph, or there is a waxing and waning of dependence. And you can catch these areas of waxing and waning or the downward trend in trying to counsel them, in trying to treat them and get them addiction free. With tobacco, the window of opportunity is small, and hence we need to jump in and try again. The ways will be discussed, but I think the initiative has to come from the doctor, the initiative has to come from the counselor in making sure they do this over and over again whenever they meet the individual, and message should be loud and clear. So let's talk about the burden of smoking. We have said that smoking is the single most preventable cause of death in the world. We've also said that the risk factor from smoking is 6 of 8 leading causes of death. So the leading causes of death are in the box here: heart disease, cerebrovascular disease, pulmonary disease, and cancer. So smoking is a predisposing factor for these 4, and 2 others within the first 8 leading causes of mortality in the world. So it increases the risk of dying by itself and also causing diseases which are leading causes of death. So what are the health hazards and what are the benefits of quitting? So we start off briefly talking about secondhand smoke. So passive smoking, as we call it, is equally important. It's no less potent a stimulus for disease as active smoking is. So lung cancer, a risk is increased by 20 to 30%. Heart disease is a similar number, and that's important. Lung cancer and heart disease form the top 2, and then stroke, again, similar numbers. Secondhand smoke exposure causes more than 8,000 deaths from stroke annually. Approximately 700 million children, nearly half of all children in the world, are regularly exposed to secondhand smoke. And children exposed to secondhand smoke are at increased risk of sudden infant death syndrome, asthma and respiratory disease, and ear infection. I believe passive smoking for children is one of the most important things that we should discuss about. Hence, a bit more of facts. These are from the report of Scientific Committee on Tobacco and Health, and also from the Royal College of Physicians document from 1992. Children whose parents smoke have a 1.5 times greater risk of having asthma, 57 to 72% increased risk of respiratory disease, and they inhale nicotine in amounts equivalent to them smoking 60 to 150 cigarettes per year. 60 to 150 cigarettes a year, mind-boggling numbers. And children whose mothers have smoked during pregnancy, much greater chance of developing sudden infant death syndrome, as we said, and about a 1.6 times greater chance of developing a lung infection. So children, your children who smoke passively, your patients' children who smoke passively are at a huge risk of dying or having significant morbidity from their parents having smoked. They're not to blame at all for what happens to them. What about the causal linkage of various diseases to smoking? So on the right of this graph, as you see on my cursor, are chronic diseases, and on the left are cancers. Let's start off with the chronic diseases first. Some of the diseases that you see on there are ones that you would anticipate anyway. So the stroke, the coronary artery disease, the pneumonia, atherosclerosis, COPD, asthma, TB, diabetes are ones you know. But the ones that I'm not reading are important because you wouldn't anticipate that these factors are caused by smoking. Eye problems, so the cataract, age-related macular degeneration, dental problems, periodontitis, reproductive defects in women, including reduced fertility, fractures, including hip fractures. All of these are chronic diseases that are also significantly related to smoking. Let's now look at the cancer basket. The obvious one is lung cancer, and you can see it on there somewhere in the middle, trachea, bronchus, and lung. Maybe esophagus, larynx, and oropharynx, then in the upper part of the airway, the upper part of the body. And they are also obvious causes which are linked to smoking, cancers which are linked to smoking. But then look at the remaining list, the acute myeloid leukemia, the pancreatic and liver cancers, the kidney cancer, the cervical cancer, mind-boggling. There is hardly an organ in the body where malignant transformation might not happen due to the hazards of smoking. Here we have talked about smoking. Remember, oral tobacco has similar decrements, it has similar problems, and oral cancers, laryngeal cancers, upper airway cancers are as rife with oral tobacco, if not more, as compared to smoking. This is a lovely study, which is recent, which is about 6 or 7 years old, which looks at loss of life from smoking cigarettes throughout adulthood. So this study presumes that smoking starts at around of age 835, and they follow these patients up to the age of 80 if they survive till that age. This is after the Fletcher-Peto curve, the famous Fletcher-Peto curve, which looked at the problems with smoking, the morbidity and mortality associated with smoking, and then the benefits that you accrued by stopping at different ages. This, however, just compares two groups of people, a group of people who've never smoked and a group of people who have smoked from 35 for their entire lifetime. And I want you to look at 3 different countries and continents which are on that slide. There's United Kingdom, there's the USA, and there is Japan. And you can see that in the UK, men and women, same for the US, men and women, and in Japan, men and women, there's a reduction of lifespan of 10 years when you compare people between those who've never smoked versus those who've smoked from the age of 35 and beyond. A loss of 10 years in lifespan is huge. And the mortality that you attain with cigarette smoking probably supersedes any of the other factors that we spoke about a little while ago. So when do you get benefit from quitting? And this again is a lovely slide which tells you what happens when you stop smoking, what happens immediately, what happens later on. So within 20 minutes of stopping smoking, your pulse rate will return to normal. About 8 hours down the line, that's only 1/3 of a day, the carbon monoxide levels reduce to half, oxygen levels return to normal. 2 days of quitting, carbon monoxide is eliminated. Within 72 hours, so that's 3 days, breathing is better, bronchial tubes relax, so there's better bronchodilation with the smooth muscles of the bronchus having relaxed, and the energy levels increase. 3 to 9 months, lung function increases, improves by 10%. So that's within 9 months of stopping smoking. Within a year, the cardiovascular morbidity is reduced significantly. Heart attacks reduced by half compared to that of smoker. By 10 years, lung cancer risk falls by half. And by 15 years, the risk of a heart attack is the same as that of a never smoker. So starting off within 8 hours, up to 15 years, you accrue years in life, your mortality reduces, your morbidity goes down significantly. Hence, the adage, it's never too late to stop. I'll talk briefly for a minute about the science behind tobacco addiction. This is the DSM-5 criteria for tobacco use disorder. There are 11 criteria on that list, of which at least 2 must be present in the last 12 months for it to be called a tobacco user disorder. If this is an area which interests you, I would implore you, I would request you to go through the DSM-5 criteria, because it at least gives you a mental understanding of factors that you're looking at. I won't read through this list for the want of time. However, there are factors about how much of tobacco and for how long the person has taken it, whether there is actually a desire on the part of the individual to stop smoking or use tobacco or not, whether there have been multiple or single or never effort to stop in the past, how strong is the craving or desire to use tobacco, what are the recurrent users' patterns, so whether the person smokes in bed or not, for instance, and multiple other factors. So that's to define tobacco user disorder. And then you have nicotine dependence. Nicotine dependence, according to the World Health Organization, other international societies, are unsuccessful attempts to stop smoking, difficulty to control usage, and previous experience of withdrawal symptoms during a period of abstinence. The withdrawal symptoms are listed there: the mood disorder, the depression, the insomnia, irritability, anxiety. All of these factors make tobacco smoking cessation the most difficult cessation program ever in mankind. A word about deaths and then we'll finish. I want you to focus on a couple of things on there. The fact that lung cancer causes 1/4 of deaths from smoking, COPD caused 1/5 of the deaths from smoking, and other respiratory diseases. And when we say other respiratory diseases, we mean diseases like asthma, interstitial lung disease, etc., caused 1/10. So 1/4 for lung cancer, 1/5 for COPD, 1/10 for other respiratory diseases. But prominent up to 1/5 is also ischemic heart disease. There are other cancers, that there is an impairment in the circulatory system, and even the digestive tract is affected. And these gives you numbers, the number of deaths due to smoking and the percentage of deaths due to smoking in men and women. And you can see respiratory disease and cancers are right at the top as expected in this list. What about fatal diseases associated with smoking? You can see cancer again at the top and COPD, but in the cancer list, there's also tobacco cancer, there's also bladder cancer. There's also cancer of the esophagus and kidney, which promotes what I told you before, the fact it's not just about the lung, even though the lung is the most important along with the heart, it's also about other organ systems in the body. So I finish off by again underlining the fact that tobacco and smoking is the most addictive behavior known to mankind. This has a massive impact just on lung health, but also every other part of the body. We have tried through the course of this talk to underline how important this is from a morbidity and even more importantly, from a mortality point of view. Quitting is difficult. However, if you do manage to quit, the effects are immediate and you will continue to accrue benefits from stopping smoking after 15 years of having stopped. So lots of incentives for you to stop. You will now listen as to how you go about getting your patients or getting your family or yourself to stop smoking, and then a great panel discussion which will put it all in the lung cancer perspective. So happy listening, and thanks again from all of us in the Indian Society for having come about with this meeting. Thank you very much.
Thank you, Dr. Raja. Thank you very much for your nice exposition of the subject on tobacco use and its impact on the human health. Now I move to the third speaker of the day, Dr. Withdrawal. She is a director in Federity Research Solutions Private Limited, Chennai. She is going to speak on the optimal use of pharmacotherapy in tobacco cessation. Dr. Withdrawal, please.
Yeah, yes, sir. Thank you so much for this opportunity. And I think Dr. Raja and my previous speakers have set the ground. And basically, when we talk about lung cancer, most of the people will be asking a question like, now it is more, as you all aware that most of the time the lung cancer patients are also diagnosed at an advanced stage. So most of them will be asking, in this stage, is there any benefit if we make them to quit, or should we leave it like that, or is there any benefit that we put pressure on them to quit the habit? Uh, of course, the benefit is multiple, and every aspect. If you look at, the benefits of quitting, Dr. Raja also presented, and the same benefits are added to the lung cancer patients also. But here, what will be the problem is when a patient comes to a cancer hospital and meet a clinician, they will be coming with a lot of problems, a lot of symptoms, and the family also will be putting a pressure on them, that and the guilt, they will develop guilt over the patient, like, okay, why did you get this cancer? Only because of smoking you got this cancer, so at least now you quit. Even the people, the family members who have not put pressure before, will start putting pressure on them when they are diagnosed with the cancer. So this become an additional pressure on the patient while suffering with the symptoms associated with the lung cancer. Making an effort to quit will be an additional burden on the patient themselves. And for a clinician, particularly the lung cancer specialist, the oncologist, they have a challenge whether to concentrate on the lung cancer treatment, or should we be focusing so much on the tobacco smoking cessation, because smoking cessation itself is a separate treatment process, and so much efforts and treatment burden is there on treating the disease itself. So they have to play a dual role in this context. So where will we give the priority? Like, should we be concentrating and spending our time on smoking cessation, or will we be spending more time on treating the disease itself? And here the family will be developing a guilt, like, stop smoking, all everything happened because of smoking only. That burden will push, and all sorts of pressure and anxiety will be there. But at the same time, the patient also will be finding it difficult to cope up with the disease and its related symptoms. So here in this context, how will we go about it? And will there be a benefit in making effort or simultaneously trying for smoking cessation also? So of course, there are benefits. Where the evidences are saying more than 40% of the lung cancer patients were diagnosed. At the time of diagnosis also, they were smoking. And some patients would be suffering with the symptoms for about 6 months to 1 year. And due to symptoms, they would have stopped smoking 2 months or 1 month, or previous months they would have stopped. But most of them continue to smoke even at the time of diagnosis. And more than 80% of them continue to smoke even after the diagnosis also. So smoking cessation brings benefits in terms of improving the quality of life and in the treatment response. And there are evidences proving the smoking cessation bring additional benefits in terms of survival and quality of life. And even the people who are undergoing treatment, the surgery related complications also will be minimized if they quit even after the diagnosis. So it's not too late. And even the chemotherapy responses increases. And so every clinician parallelly, if they want to reduce the number of multiple hospitalization and reduce the complications related to treatment and improve the efficacy of the treatment after the the treatment completion, we need to make efforts for smoking cessation. So it has to be integrated into the oncology treatment itself. But at the Cancer Institute, we had the privilege of having a separate department for smoking cessation. And as soon as the patients are diagnosed, and when they are found out, they are smoking habit, and the family members themselves will come and report to the doctors, and they are immediately referred to a smoking cessation clinic. And initially, in the initial days, when the patient was referred to a smoking cessation clinic, they do not come and attend, because in the busy hospital, and they have been undergoing multiple investigations and schedule appointments with the doctors and other things. They will not be able to, even the family members will be finding it difficult to schedule an appointment with the smoking cessation expert when it is functioning as a separate department. But they, and also the clinical oncologist, they will be forgetting to follow it up. Whether you have gone, I referred you, did you go and attend the cessation clinic? So these follow-up also will not be there because they will be busy with their own treatment process and other things. But because there is no insistence from the oncology team, and they, once the referral is made, if they don't make an attempt to go there, or once they make an attempt and they see, okay, there are a lot of, there is no active any treatment, or they don't give immediately any medicines, they don't find any reason going there, so they just give up. But now later what we have done is, like we have integrated that into the, now I'm at present, I'm not at the Cancer Institute. I moved to a rural setting in a Nellai Cancer Care Center. But still, I'm just trying to, because of my previous experience with the Cancer Institute, I would like to elaborate more on the Cancer Institute setting now. So what they do, they have given access in the MedMantra, in the in the computer itself, whether the patient has gone to the smoking cessation expert, that will be reported, and what is the recommendation, whether the medication has been given, or what is the next review date, everything will be documented over there. So when a clinical oncologist see in their OPD, all these histories will come, whether they have attended and when is the next review date. So he will give an additional reminder, like, whether have you gone there, and hope you will be able to quit. I hope Pratima Murthy will be enlightening about the other part of the behavioral aspect of the smoking cessation, where, a little bit of, we continue to train the oncologist in the 5A approach and the behavioral aspects of the smoking cessation. So they also continue to make efforts in their routine OPD to advise them, to educate them that it is very important for you to quit smoking cessation, to have an efficacy in terms of the treatment also. So in that way, when the smoking cessation expert and the clinical oncologist, when they work together, the quit rate increases, and at least the attending rate, the participating rate increased in the clinical setting. Then one step ahead, what happened is, like, immediately the cessation expert talk to the oncologist, and they together make a plan for what kind of intervention will suit. Is it a first line is it smoking cessation? Only behavioral intervention is enough, or the next step, are we going to treat them with the nicotine replacement therapies, or based on the severity of the addiction, do we immediately require any medications? So these things are decided in discussion with the clinical team. So that there is a tumor board, and we encourage the tobacco cessation expert also to go and participate in the tumor board when such cases are being discussed. So together, it's a, we need to work with all the disciplines so that the efficacy of quit rate increases, and the treatment outcome is also ensured. So in terms of pharmacotherapy, I'm sure Dr. Pratima Murthy also will touch upon that. And nicotine replacement therapy is considered as the first line of therapy. And whatever the pharmacotherapy we prescribe them, it has to be accompanied with the behavioral intervention. Without behavioral intervention, in the smoking cessation, any pharmacotherapy we give, that is not going to bring the desired results. So we always advise the clinical oncologist, because they do not have time, they can refer the patients to the smoking cessation expert, or the counselor, or the social worker, or psychologist, or any paramedical staff who is sitting in the hospital. They can be trained in smoking cessation, and their help can be taken. So in a big way, the treatment will be cost effective, and the patient also can smoothly come out of the disease, and they can have improved survival rate and the quality of life. So what is very important is, one is the smoking cessation has to be integrated into the oncology setting, and it definitely brings some positive results. And if we do not have time, we can integrate an additional supportive staff who can be trained in tobacco cessation, and their help can be taken. So if there are any questions, maybe we can address that during the panel discussion. Thank you so much for the patient listening.
Thank you, Dr. Vidubala, for your nice exposition of the subject of optimal use of pharmacotherapy. Now, a last speaker of the day, effective behavioral cessation approaches in the smoking cessation. And I invite Dr. Pratima Murthy, who is the Director and Senior Professor, Department of Psychiatry, National Institute of the Health, Mental Health and Neurosciences, Bangalore, one of the premier institute of the neurosciences in the country. Dr. Pratima.
Thank you very much, sir. Would you allow me to share my screen, please?
Yes, ma'am.
Right. Thank you very much for asking me to speak at this session. A few months ago, I was asked to speak to hepatologists on management of alcohol dependence, which was wonderful because, it's very nice to have specialists focusing on addiction, which normally they're a little averse to deal with. So similarly, I'm very pleased that a group of pulmonologists and other lung specialists have chosen the topic of tobacco cessation. I was asked to focus on the behavioral aspects, which I will do in the next few minutes. But of course, the important thing that I'd like to underscore is that the current evidence suggests that a combination of behavioral as well as pharmacological approaches is possibly the best thing for tobacco cessation. I'm very glad that the organizers shared a lot of resources on the importance of quitting smoking in patients with lung cancer. It's obviously a very important preventive strategy to prevent people from developing lung cancer, because we recognize that tobacco use in all forms are associated with a variety of cancers. Most of the documents shared by the organizers suggest that quitting smoking is very, very important, both with a beneficial effect on survival as well as improving the quality of life. And therefore, patients with lung cancer need to be provided tobacco cessation support. Now, the important thing to understand is that tobacco cessation services can be provided at multiple levels. You don't need a specialized tobacco cessation clinic facility to provide tobacco cessation services. There are mental health practitioners who might provide these services. They might be community health workers or lay counselors, but I've underlined that the individual healthcare provider is perhaps the most important person to offer tobacco cessation services, because you are seeing the patient at a time when the patient comes to you with a concern about their health. And this moment of consultation is a very appropriate time for behavioral change to occur. So every solo practitioner must be able to do simple tobacco cessation counseling. We also know, and this is not new evidence, this is evidence for the last 20 years, that a physician, even if a physician spends as little as about 3 minutes talking to the patient about the importance of cessation, there can be an increase in quit rate. Of course, if the contact with the patient and the discussion around tobacco cessation is more intensive or more frequent, progressively, the chance of the patient being able to quit increases. And therefore, a brief intervention by a physician can go a very long way. And that's really the important advice in the 5 A's. All of us know, I think, about the 5 A's. We keep talking about the 5 A's, or the 2 A's and the referral, which is ask, advise, and refer, or ask, advise, assess, assist in the process. So the first question obviously is asked, and I'm sure every physician now understands the importance of asking every patient about tobacco use. Dr. Dhar mentioned it's important to ask not just about smoking, but also smokeless forms of tobacco. It's important to ask the patient if they're a current user, if they've been a past user, the frequency of tobacco use. Dr. Dhar mentioned, the light, heavy, and medium smoker. There are also other ways like the Fragostrom's questionnaire to ask people about their severity of dependence by focusing on the not just the quantity of cigarettes, but whether they smoke more during the early part of the day, whether they have to smoke within 5 minutes of getting up, which is an indication of high levels of dependence. We also ask about the duration of use and the last use. As I mentioned, we assess the severity of addiction. You can do that based on a DSM, ICD, or indeed the Fragostroms or any other questionnaire on the severity of dependence. It's also important to assess what are the reasons why the person goes back to using the next day. So whatever was the cause for using tobacco in the first place, the reason they continue to use is because of craving, an intense desire to use tobacco or any other substance. Tolerance is again another factor, which means successively over the years, people have been increasing the amount of tobacco sticks to get the same desired effect. Withdrawal symptoms are also very important to ask about. And these with tobacco withdrawal include classically irritability, inability to concentrate, feeling low, appetitive disturbances. These are the most important withdrawal symptoms. And of course, craving is also a withdrawal symptoms. I spoke about the Fragostrom's tobacco dependence questionnaire. These questionnaires, basically the most important questions are quantity and frequency. And does a person use tobacco even when they're so ill they can't get out of bed, or in places, do they use it in places where it's forbidden? These questions help you to understand the severity of tobacco use. What is the motivation of the person? Are they ready to give up? Are they doubtful, particularly at a stressful time, like when there's a diagnosis or when they're going through, emotional difficulties? They might be doubtful about being able to give up, and we must recognize if they have a difficulty, and it's better to acknowledge it than simply tell the physician to make the physician happy that yes, they're going to give up and not consider giving up. So sometimes they're ready to quit straight away, or sometimes they would like to reduce it. Now you're in a situation where they've had a serious diagnosis, and therefore it might be important to make sure that when you ask the patient about quitting, you offer them, you tell them that if you support them in the quitting attempt, would they still be willing to quit tobacco? So advising all current users to quit, educating about the addiction potential and the consequences of continuing to smoke in spite of having had a diagnosis. Then, of course, I'll come to the brief tips of how to handle withdrawal and craving, and also making environmental changes. Typically, after a meal, if the cigarette packet is close by, they reach out. With coffee, they reach out, and so on. The next thing is to fix a quick date, and normally you do it within the next few days, because if it's too remote, they will not do it, and therefore you ask them to think of a quit date in the next few days. And the most important thing is regular and frequent follow-up, not just for their physical status, following them up on their treatment for their lung cancer, but equally also to check on their tobacco use status. Advising is very important to be personalized. So for this particular individual, what might be the risks of continuing tobacco use? What are the advantages of quitting? It needs to be specific. And Dr. Vidubala mentioned that it needs to be non-judgmental, because already the person is under a lot of guilt, wondering whether the smoking itself has caused the lung disease. Family members are piling upon the individual. So it's extremely important to be non-judgmental in the stance. So an expression of empathy, recognizing that tobacco addiction is indeed a very, very strong addiction, but at the same time, encouraging the person to quit and offering your help is very important. Personalizing the change in terms of not just general advice on how people quit, etc., but a plan for the individual to quit becomes very important. what do you talk about addiction? And one of the things to tell people about addiction is exactly this, that addiction is not something that they willfully do. It's because of the brain changes that occur, how nicotine acts on the reward pathway in the brain, the same place where alcohol, opioids, cocaine, etc. act, and how these neurochemical disturbances maintain the drug habit. And when the person stops, the reasons for the withdrawal symptoms. If one explains this scientifically, people don't feel so guilty. They understand that this is a biological process, that addiction is a disease, and then they are willing to engage more in the treatment. Providing self-help booklets are very useful, offering medications if needed. Now, I'll be happy to talk about pharmacotherapy in more detail since my topic was only on behavioral. I haven't included the slides on pharmacotherapy, but combining pharmacotherapy and behavioral therapy is very important. So simple ways of handling craving are the 4 Ds, which is delay the craving because the craving will go away after some time, distracting oneself, deep breathing, drinking sips of water. These are all very commonly used strategies to handle the craving. To handle the withdrawal, people must understand that the withdrawal occurs after a few hours after the last smoke, and it is maximum in the first few days and then wanes after the first couple of weeks. The most common symptoms are poor concentration and irritation. Pharmacotherapy helps with withdrawal, as do other things like, for example, keeping something in the mouth like long or chewing gum or something like that, which the person can suck on. Keeping the hands busy are simple strategies to deal with withdrawal. Also very important to stay away from high-risk situations, particularly where there is access to tobacco use, and repeat to them the reasons why the person is actually quitting. How do you increase a person's motivation? One of the questions we always ask patients first is, what are the advantages for you from tobacco use? Patients are often stumped saying, no, it got me this, it got me into this trouble. But then you make them understand that if there was no benefit that they were getting from the smoking, they wouldn't have done it in the first place. Then you talk about the not so good things, which might be how it's already influenced the person's health, what can happen worse if the person continues to do, especially things like coughing, effects on the heart, effects on all the other body systems, which can occur if the person continues to use tobacco. What are the good things about quitting? Even if I have cancer, that it is important for me to quit because my immunity would improve, my response to medication might improve, my quality of life might improve. What are the fears about quitting? Fears are often, what will I do when I have craving? What will I do? I feel so depressed. What do I do? I might have withdrawals. I might get easily stressed. These are the important things that need to be addressed. And
Dr. Pratima, just a request. We have to wind up for the next short of time.
Do you want me to stop right now? I will stop.
Yeah, I can conclude with your concluding say.
Sure. So you need to understand that follow-up improves outcomes. So keeping patients in follow-up is very important. Teaching people how to manage stress is very important. I'll just mention to you that we've got a project called Impact, where we've looked at in detail about how to help people to actually go through this counseling. You need to know about Cessation, where you can call a Cessation on this particular number. You will get a short message service. So even if you don't have the time, you can always ask your patients to call in on this toll-free number and get messages for tobacco cessation. And we've shown that even Cessation, there was an almost 20% stopping of patients of tobacco use. There is the National Quit Line, which is there in Delhi at NIMHANS, at the Tata Memorial, and at the Barua Cancer Institute. And we demonstrated during COVID that people who called during the COVID, actually among the registered patients, the cessation rates really doubled. But we have miles to go. Right now, we've done a survey in the 101 hospitals in Bangalore, where only 4 out of 101 hospitals had a separate tobacco cessation clinic. Only about 1 in 4 physicians actually provided services. And it's very important, therefore, that all physicians learn to provide services for tobacco cessation and combine pharmacotherapy and behavioral counseling to produce benefits for their patients. Thank you very much.
Thank you, ma'am.
Thank you very much for your nice introduction of the subject. And it is very clear that without behavioral changes, condition of smoking
Oh, it's
is not possible.
I come early nowadays. 5.
I think with this
पहले था ना मेरी बाइक चली जाती है 9:30
this
कौन
purpose,
बर्तन उठाएगा
and I hand over mic to the host of the conversation. At the end, I thank to the Lung Academy of the Lung Cancer for inviting me, asking me to chair this session. Thank you very much. Please, host.
Thank you, sir. I would like to invite Dr. Sanjay Sharma sir. Dr. Sanjay Sharma sir is the director of Asian Cancer Institute, professor, head and neck department of surgical oncology, Asia Kambala Hill Hospital, Lilavati Hospital, Raja Hospital, Mumbai. We welcome you, sir. You can proceed.
Thank you, Rohan, and the organizers to have given me this opportunity. Can you hear me?
Yes, sir.
It's a really privilege, and I was listening to all those things, and for lung cancer, it was one of my specialties. As I was chief of the thoracic surgery before I left Tata Memorial, I had the thoracic surgery department in Lilavati and Bombay Hospital. Anyway, it's been a pleasure listening to the people, and I think Rohan is going to conduct next panel discussion. Will be a really treat. Unfortunately, I have to leave in between somewhere because I have got some previous prior appointment. But anyway, I'll try and to stay as long. So I invite the panelists. Apart from Rohan, we have Dr. Gauri. Yes, Gauravi Mishra. She's actually basically from the Tata Memorial. They are doing anyway a fantastic job of the preventive oncology and their sections. And then I have to invite Dr. Rakesh Gupta. He's the president of the Rajasthan Cancer Foundation and is working as one of the experts in de-addiction and Department of De-addiction at the SDM Hospital, Jaipur. I invite Dr. Prabhat Malik, who is additional professor, Department of Medical Oncology at the All India Institute. Dr. Susan Nathan, she's basically an honorary scientist at School of Preventive Oncology from Patna. And I had a pleasure of meeting her earlier with my colleague, Dr. J.K. Singh at Mahavir Cancer Sansthan, and earlier it was working. Of course, Dr. Jindal needs no introduction. He is the Emeritus Professor of the Department of Pulmonary Medicine at Chandigarh PGI. Dr. Pratibha Murthy just gave a fantastic lecture. The director of Department of Psychiatry at National Institute of Medical Health and Neurosciences at Bangalore. And of course, last but not the least, Dr. Vidhu Bala, who also gave a good lecture prior to this, is from FINI Research Institute of Chennai. So I hereby hand over to Rohan to take over the interesting subject of the problems of smoking, smoking suggestions, cessations, and the success that we have achieved over last decade or so. We think immense, but I think we still need to do a lot of things. Over to you, Rohan. Take care.
Thank you. Thank you so much, sir. And welcome all the panelists. I request Dr. Gauravi to proceed with the questions.
Yeah, thank you, Dr. Rohan, and thank you, Dr. Sanjay Sharma. Good evening, everyone, and welcome to this panel discussion on basically a very different topic as such, that is embedding tobacco control within the clinical oncology programs and setting up the clinic. We want to see how feasible or how difficult it is to set up a clinic in an oncology setup. At the outset, I would like
come and listen to them. If you want to listen,
no,
they won't see you now.
To co-moderate this session and also for including this very important topic in today's discussion. Herein, I would like to begin with a recap from the previous speakers that tobacco use is one of the biggest public health threats that the world has ever faced. And it is again the largest preventable cause of death. And today we have a great panel of experts, from varied fields with huge experience, not only in their core competency, but having worked very intensively and aggressively in the field of tobacco control. So without any further delays, my first question is to Dr. Rakesh Gupta, who is a surgical oncologist, but also very well known for his efforts in the field of tobacco control and cessation. So Dr. Gupta, I request you to share your experiences in the field of tobacco control and especially tobacco cessation in brief, and then extend the discussion about its applicability in the oncology clinic setup. Dr. Gupta, please.
Thank you, Gauravi, for the invite, and good evening to all the panelists and participants. My experience in tobacco cessation extends from quitlines to tobacco cessation clinics establishment as well as their operationalization, plus training the healthcare professionals in tobacco cessation delivery at the state level through the tobacco cessation clinics. And also I have worked with the state medical helpline to empower the counselors to deliver the quitline services in an informal setting. I consider that the applicability of tobacco cessation clinic in oncology setting is definitely possible. I think there is a willingness on the part of the oncologists as well as but the issues is we need to see it in the terms of two things. One is that we need to know who are all the stakeholders. So stakeholders, if I enumerate from the priorities, top priority one is the management. The concurrence is required from the management. We require a wholehearted support of the administration for whatever are the needs. Then we need to have the hospital reception and hospital information system, which can help us identify the patients who are tobacco users. And also we can manage our data in a way through the initial information that is provided by the patients and attendant, but also through the tobacco cessation clinic for what all has been done in the management of tobacco cessation. A very critical component, of course, undeniably is the participation of the consultants or the doctors in tobacco cessation delivery. Their willingness to deliver tobacco cessation at every clinical counter is every clinical encounter is very, very important. But lastly, but most not in a way less important is the participation of the patients and the attendants, who in a general hospital setting or even in an oncology setting comes primarily for the ailment which is affecting them, be it myocardial infarction or whether it is stroke or it is lung cancer or cancers of any type. Their focus is more on getting the treatment for the disease rather than getting the tobacco cessation delivery. So all these stakeholders engagement is very important on a sustainable basis. And I consider the leadership has to come from the management. I'm emphasizing this point because I consider that we have already moved in the private healthcare setup. So it's very important that the management is roped in or management takes the proactive action. Second part that I wish to say here is the use of systems approach. Systems approach primarily means screening the patients who are coming to the hospital for tobacco use, treating them appropriately in the tobacco cessation clinic or otherwise through the consultants for tobacco cessation delivery, and following them up on a regular basis, at least for 6 months, so that they get supported for the needs they have in quitting tobacco, control of the withdrawal symptoms, and prevention of relapse. This systems approach I consider is very critical because the hospitals have to be engaged in tobacco cessation. The system should know that there is also a win-win opportunity for everybody who is involved in tobacco cessation. And now that it is being looked in from the business point of view, it's very important that there is a profitability also in tobacco cessation delivery. Return on investment, I think, is very high. We need to perhaps calculate it for the country. So this is where I will stop for the question that has been asked to me.
Thank you, Dr. Gupta, for highlighting the systems approach and also for emphasizing that every opportunity, whether the patient wants it or not, he has come for any complaint, but we make use of the opportunity to emphasize on tobacco cessation. Now, my second question is to Dr. Jindal, who is also a pulmonary medicine specialist. So I would like to know from him, in your clinical practice, what percentage of the respiratory morbidity patients are actually tobacco users? and it's which form of usage, basically smoking or smokeless, and how actually patients quit on hearing about the diagnosis. How often they would substitute to other forms of tobacco, or is there any relapse after cessation? So Dr. Vidubala also emphasized on this point. Her opinion, what she saw was that the patients don't quit. 80% would continue even after the diagnosis, hearing about the diagnosis. I would like to hear about your experience.
Well, thank you very much. I think it will not be an exaggeration to say that most of the respiratory diseases are linked to smoking in one way or the other. See, some are directly linked to tobacco smoking, like chronic obstructive lung disease or COPD and lung cancer. Interstitial lung diseases, which are increasing now in prevalence, they're also largely seen in among smokers. See. So, in fact, the COPD patients, almost 80% of them are related to smoking, and even amongst female, there are, of course, maybe different factors, either smoking or exposure to other type of combustions, smoke from combustion of biomass fuels and so on. Then there are other morbidities like bronchial asthma, or even pneumonias, infections, which are indirectly related to smoking, because smoking is an important risk factor. Moreover, smoking may be an aggravating or trigger factor in several of these diseases. So I will say smoking is a very important cause. I will say that many of them have already quit smoking once they start coughing. You see, the patients of COPD or asthma, it's generally because they themselves start attributing it to this. They get the symptoms when they smoke, you see. So everybody advises them to quit smoking. I think a large number of these patients, whether of COPD or asthma, they have either quit or they're willing to quit. But there is the help to quit is generally meager, I will say, although the physician who is looking after these patients will always, we have always been taught about the 5-way strategy, that we should always ask, advise, and assess about smoking, etc. But I think in a busy OPD clinic, it is generally difficult to stress upon, you see. So I think many of them fail again and again, and they quit for a few months, or and then they restart. But story is different with lung cancer. Again, these patients, in fact, in the past, many of even physicians thought that there is no idea of advising quitting and stressing too much time on quitting, because they have already developed a fatal disease like cancer. The recent evidence, of course, has been discussed even in this seminar, that even for lung cancer patients, quitting is of great importance in improving the quality of life and many other things. So I think in respiratory medicine, smoking is the most important risk factor, and it is important for physicians to be sensitized to its cessation.
Thank you, Dr. Zindal, for sharing your experience. Now, my next question is to Dr. Vidubala. Dr. Vidubala, I mean, you have been working in a tobacco cessation clinic for such a long time in Chennai, and you nicely shared your experiences. Can you just throw light on, is it so difficult to set up a tobacco cessation clinic in a pulmonary setup, or what does it entail? Is it possible to set up a tobacco cessation clinic in a pulmonary setup?
Thank you, Gauravi. Basically, I would like to take the points forward from Dr. Rakesh Gupta's presentation. Like, we have trained over a period of 3 years, 188 dentists in a 5 days tobacco cessation workshop. So every 3 months, we continue to conduct. It's a paid workshop. We charge them and for their food and other materials and other things. So once the Ministry has said that, that there is no funding for tobacco cessation clinics and you have to integrate into your routine services. So we started conducting such courses. So after, over a period of time, 3 years in batches like 20 members. So we try to understand, how many of them have actually set up the clinics in their colleges or in the clinical setup. More than 90% of them, what they said was the management is not willing. They do not prioritize this. And because they do not see any benefits in setting up a tobacco cessation clinic. So I do not know how we are going to get the message to the top level administration people who do not deal with the daily routine clinical aspects. And getting a room or getting a staff or the existing staff to be trained in tobacco cessation or orient your own staff, like treat your patient. Why are you doing unnecessary things, wasting your time? If a top level management people give that information, most of the time they also strongly believe if we start a tobacco cessation clinic and if we start insisting on them to quit tobacco use, they may disappear from your hospital itself. They do not want to see the same clinician again. So in this way, you will be losing the patients if you start insisting on tobacco cessation. So the foremost thing is making to understand the importance and the benefits that we are going to have by having a tobacco cessation treatment in any clinical setting. This is the foremost thing that we need to do. The second thing, even for any mandatory thing, if we are asking them, okay, they no other go, and that's a if people come for some rating from the government inspection or something like that, now the dental clinics are asked to set up a clinic as part of their services. So if there is something being mandated, even in this context, what we see is the room and the infrastructure which is being provided for tobacco cessation somewhere near the toilet, somewhere near under the steps, some one corner. That is the importance that is being at present given to tobacco cessation. Then the training part, the trained personnel, let it be like rightly Dr. Pratima Murthy said, there is no, hard and core, like this is how it should be. Nothing like that. Even a 3 minutes of a physician's time can make a huge impact on the outcome of the tobacco cessation. So at whatever the level that we are doing, we need to put in our efforts and make the administration to convince and make the clinicians to be part of it and take this tobacco cessation aspect as a serious matter. First of all, as a prevention as well as a clinical, to be integrated as a significant part of the treatment itself. That's the biggest challenge and we need to do that. Thank you.
Thank you, Dr. Vidubala. It's really important that we keep emphasizing that even a brief interaction by a physician goes a long way in, initiating at least the thinking process that one needs to quit tobacco. So thank you for that insight. And I think, as you rightly mentioned, you have trained so many physicians in tobacco cessation. Training a large number of paramedical staff from the clinic also, it is very feasible in a short period of time. So if the 5 A's and the 5 R's, if it is difficult on a particular occasion for a physician to do it, maybe the paramedical staff who is trained in the same, who belongs to the same clinic, can take it forward. But I think not losing that opportunity that we get for interacting with the patient is of key importance. My next question is to Dr. Prabhat Malik, who is a medical oncologist, and really thank you for joining us. From you, we would really like to understand the various chemotherapy regimens that are used for management of lung cancers in terms of, their interaction with the different pharmacotherapy medications that are used for tobacco cessation, maybe nicotine-based pharmacotherapies or non-nicotine-based pharmacotherapies. I mean, whether they can be safely used in a patient who is undergoing lung cancer management treatment.
Right. So, thank you for inviting me. First of all, I would say that the interaction with smoking and various systemic treatment which we use in the management of lung cancer is quite significant. Tobacco smoke per se increases metabolism of many of the systemic chemotherapy drugs, and in fact, this interaction is much more with the more recently used targeted agents, which we use routinely in lung cancer management. The active smoking actually increases metabolism of many of these drugs, and indeed reduces its efficacy. So that's kind of well-established phenomena which we observe. So, I mean, at any point of time, stopping use of tobacco smoke is certainly useful. Sometimes even patients ask that the cancer has already happened, I mean, how it's going to make a difference, but it does make a difference in terms of the effect of treatment. It makes a difference in long-term outcome. This becomes much more important when it comes to the curative setting management, particularly surgical, definitive chemoradiation. In those situations, when we are expecting a reasonably good long-term outcome, in those situations, it becomes much more relevant. In terms of various pharmacotherapy agents which are used, for individual drug, one has to check the interaction, because we cannot use drugs which have effect on cytochrome P450. For individual drug, you have to check the drug-drug interaction. So that is important when these patients are advised for pharmacotherapy. But by and large, most of these pharmacotherapeutic agents are generally safe. If you ask me, it's a generalized statement.
Thank you for again repeating that even in patients with lung cancer cessation at any stage, I mean, it is very important that the patient sees tobacco, and cessation only improves the treatment outcomes. Thank you for that. Dr. Suzanne Nathan is with us from the ICMR, and I mean, ICMR well known for cancer research and research in every aspect of science. So I wanted to understand from you, I mean, is there some research wherein the lung cancer society, the chest society can be involved in, especially, when you're looking at the medical students, the PhD students, the MD students taking up some research topic in terms of tobacco cessation among lung cancer patients or among the chest patients as such, and whether this topic of tobacco cessation could be ingrained right from when they are in the student stage.
Thank you, Dr. Gorvi, for that question. I would like to first of all reiterate some of the points which which many of the experts have already mentioned, that other than professionals, I mean, conventionally trained tobacco cessation professionals, even physicians or even pulmonologists in the context that we are discussing in, can engage in tobacco cessation, if not full-fledged tobacco cessation with regard to behavioral therapy, pharmacotherapy, then definitely brief intervention. And similarly, like you just mentioned, this training or this basic training can also begin from medical school. And this would be an ideal situation, in fact, not only for pulmonologists, but for any medical or healthcare professional. If this training is incorporated in the medical curriculum, then that would definitely be of much more help. And especially in certain specialties like pulmonology, for example, that we are discussing today, as has been established that smoking is the primary risk factor for lung cancer, then for especially such healthcare professionals, it should be made mandatory, in the medical curriculum, to further educate them about the adverse effects of tobacco, then how to address patients when they come to you for a cancer diagnosis. I mean, of course, not only cancer diagnosis, but even other respiratory issues which are as a result of tobacco smoking, and how to take a detailed history and to continue the tobacco cessation help, and to continue it throughout the procedure of the treatment of the cancer treatment. So with regard to research, based on the currently available literature, it has been noted that in spite of being aware of the risk factors, many physicians, including pulmonologists or oncologists who are directly interacting or coming across such patients, they don't always necessarily engage in discussing about the adverse effects of smoking. Or there is also a literature available wherein they do not probably educate them about the techniques which can be used for quitting the habit, or even referral, like one expert had mentioned, that even if the physician is not able to help, they can definitely refer the patient to a suitable facility. So even that is not a common protocol. So perhaps a research could be performed on this aspect, that what are the barriers which prevent the pulmonologists or oncologists from taking these steps, or if at all, what could be the facilitators which would increase this practice among the oncologists. And secondly, another research question could be, like we all know, for any addictive habit, there are definitely a certain group of individuals who are not motivated enough to quit the habit, in spite of sometimes coming up, in spite of knowing of such grave diagnosis. So a research question could also be as to what prevents them, or what are the barriers that they need to overcome to finally engage in active tobacco cessation treatment. So with regard to a clinical setting, I think these could be some questions which could be addressed and studied further. And because especially we would like to see some evidence in the Indian setting, because as is also applicable for other research areas, the literature is not uniform or applicable for or it can be generalized in all settings. So definitely it would be nice to see certain Indian context-based studies on these aspects, so that accordingly measures can be taken and implementation research and further implementation can be improved. Thank you.
Then I mean, with a lot of the scope for research and the involvement of the Chess Society in conducting research on tobacco cessation. Dr. Pratima Murthy is an expert in tobacco control and cessation, and has been running the TCC with pharmacotherapy and and behavioral therapy for a long time now, and she's very well known in the Tobacco Control Society. I would like to know from Dr. Pratima, I mean, is there a scope now that we include the individual need mapping, the mobile health technology, artificial intelligence, collective intelligence models as future directions towards tobacco cessation in oncology setups?
Yeah, I think there's tremendous scope to use technology. We've already been using technology through our digital academy to train not just physicians, but other healthcare professionals in tobacco cessation. There are apps that are available. But at the end of the day, I think those are easier for people who might not be very heavily addicted to tobacco use, but for people who are addicted. And, one of the important things is that people perhaps who have used it chronically for a long period of time are at the highest risk to develop malignancies. So I think it's very important to recognize that from a preventive point of view, not just tobacco use, the use of alcohol, diet, exercise, ability to handle stress, many of these have a preventive role. And I think that's something that we need to focus on. But even in terms of people who have disease conditions, in order to keep their immunity intact, to prevent further problems, the importance of cessation needs to be underscored. I just wanted to address the issue of pharmacotherapy. There is evidence, for example, that NRT, although there are no long-term studies, that it doesn't cause any tumorigenesis, and therefore, it might be used at least for a 12-week period to get people off tobacco. We know that it's not safe to use e-cigarettes, for example, as a substitute, because e-cigarettes have various aldehydes which are associated with carcinogenesis. So that's something that is known. the non-nicotine replacement drugs like bupropion may actually provide some help in terms of reducing cancer-related fatigue. So that's again another area. And similarly, there are studies about varenicline and its possible use potential in patients who have lung cancers in terms of tobacco cessation. So I think there is a lot of scope. Patients are afraid when they come with a diagnosis of lung cancer. The physician should be able to make them confident that it is possible to quit and improve their lives and support them in the quit attempt.
Thank you, madam, for also including your experiences with pharmacotherapy. Just to add on it, I mean, with varenicline, the suicidal tendencies, how much do you see it, and what do you say?
Yeah, so earlier there used to be great concerns about the suicidal tendencies, and there were black box warnings as well. While it is important to kind of make sure that you're monitoring patients, now it is known that these were not as much as it was thought about earlier, but obviously it has to be given under medical thing. And in fact, there is some studies suggest that extended treatment with varenicline actually might be very effective in patients, but these are very small and few studies in between. But there's nothing to suggest that outcomes have worsened. So I think there is hope in pharmacotherapy as well, in addition, of course, to the behavioral interventions, particularly in patients who have severe addiction.
Thank you, madam. And I'll ask one more question, and then I think I'll hand over to Dr. Rohan to really decide how much time we have and how we can take it forwards. But before I end up, I want to ask one question to Dr. Rakesh Gupta. I mean, we have this National Tobacco Control Program, and under this program, we have one tobacco cessation clinic by the government, which we are permitted to establish in each district of our country. And with 29% of our adult population using tobacco in one form or the other, I mean, can you describe what would be the significance of this single clinic at the district level, and what is the importance of it?
This is a good question, actually, and I consider that the one tobacco cessation clinic at the district level doesn't suffice for the number of tobacco using patients we have at any health facility at any given time. So it's important that tobacco cessation delivery becomes the norm for all the healthcare workers. I'm extending my comment beyond the doctors. For all the healthcare workers, their participation should be mandated, and they should be appropriately empowered, which is also possible because as Dr. Pratima has said and Dr. Vidubala has said, empowerment is not difficult. It is the attitude of the healthcare workers and the doctors to deliver it. Because if it takes 1 to 3 minutes or at the most 10 minutes of the patient's time in your clinic, it is worth giving it. And especially in reference to the cancer and lung cancer, there is a lot of evidence that when you do that, it also helps to reduce the progression of disease. It also reduces the occurrence of the second cancers. There is a recent study, which has a prospective study in over 500 Russian patients. And this has clearly shown that it not only helps the patients, and this is primarily for lung cancer patients, that it helps to reduce the progression of disease, and it also gives them a longer duration of disease-free survival. So I consider that it is absolutely necessary that we move from one TCC clinic in NTCP to clinics TCC integration at all levels of our healthcare system, not necessarily to have a tobacco cessation clinic, but I consider it's time that we think about mandating our healthcare workers to deliver tobacco cessation.
Thank you, Dr. Gupta. Dr. Rohan, I mean, you may advise if we can go ahead with some more questions or...
Yeah, I just want to request Dr. Digambar Bera to give his inputs about some take-home messages. So you're on mute. Okay.
Yeah. Okay, thank you. very much for inviting me and the associating Indian Chess Society as well as Indian Society for Study of Lung Cancer with this endeavor, which we are already carrying out regularly. I think we heard from leading experts of the country on the topic of tobacco use, then its harmful effects, and what are the benefits of tobacco cessation and how we should go forward. It's a very nice and excellent deliberation, I should say, over the last 90 minutes or so, and that was followed by a nice panel discussion, which important issues were raised, discussed, and answered. My limited point is that since our focus was lung cancer, of course, it is not only confined to lung cancer. In general, it is applicable. There is no specialty which is actually not affected or not directly or indirectly related to tobacco smoking. And you take any specialist, the disease of that specialty will have some connection with the tobacco use. So I think that is very important message, at least I got it. Secondly, in lung cancer, our one may ask the usual question, lung cancer patient in any way is going to die, why you want to take, to tell him not to smoke. I think it is very, very nicely told by the experts why it is very important. And now the lung cancer 10 years back, 15 years back is not so now. The longevity, the median survival time, the progression-free survival, everything has increased now, that we all know. So as most of these very rightly highlighted, how the quality of life, the prolongation in survival, and other things improve with the tobacco cessation. And when there is a life expectancy is also increasing with lung cancer, with the newer modalities of therapy, treatment, be it targeted therapy, be it immunotherapy or good chemotherapy. So I think it is very, very important. And even some, although it is very few, some percentage of cases in very early stage of disease, if they undergo surgery, they also survive longer. Their 5-year survival is more than 60%. So obviously, there is a very good case for tobacco cessation in them also. So I'm just trying to tell about the positive aspects and why it is very, very important, even apart from the more advanced form of the disease. And again, I think one point which was highlighted, being highlighted as a pulmonologist, I know from the times of Pito when they started the study in British doctors, and then the benefits of quit smoking. And it is very well said that no age, it is never too late to stop quitting. I think that will be the message for all of us and every physician, every student of science, and with a multi-pronged approach through, we have got national experts, we have got Dr. R.C. Gupta, we know, we have heard, we have listened to him, and we have got Madam Pratima Murthy, the Tata Memorial people, and everybody is there, and we have a large society of Indian Chess Society, we have National College of Chest Physicians. So let us all work together and emphasize the government, although they have got a National Tobacco Control Program, that should be more effectively implemented throughout the country. So with these few words, I thank you, Rohan, for giving me this opportunity to chair this important and for very, learning exercise, at least for me. Thank you very much, and good night, everybody.
Thank you so much, sir. We have come to our towards the end of our program, but I would like to mention this was one of the best program ever attended for tobacco cessation, getting one of the best minds in the country. And I would like to really thank Dr. Kumar Prabhas to even have this thought to include such kind of a program in a scientific sessions for the oncologist community and extending it to a different level. So we are taking it to a different level, and that is the need of the hour, which was very evident. Each speaker had so much to give back, so much of knowledge, but they don't get such kind of platform. The problem is that today, but I really thank Dr. Kumar Prabhas to get this best minds on a platform where they could, explore, and this knowledge could be spread to more people. And I would like to thank each and every panelist. To begin with, Dr. J.K. Sumaria, the chairperson. I would also like to thank Dr. Jindal, Dr. Vidubala, Dr. Murthy, Dr. Gupta, Dr. Malik, Dr. Nithan, and I was coordinating this session with Dr. Raja sir. And I would also like to thank Dr. Gauravi Mishra, who at the very last moment, she has actually done a very good, excellent job. And I would also like to thank the other coordinating members, Dr. Rekha and the TMH team of Dr. Kumar Prabhas sir. And I would request Dr. Kumar Prabhas sir that this should continue and give us more such platforms where we could again and again come up and get this innovative ideas from the best minds, so we can, wherever part of the country we are, we could give whatever bit from our side and get this best idea so that our work in this field improves. So it was indeed an excellent session. I would like to get this recording because every point mentioned was important, and I would like to go through it once again. Thank you so much, everyone. Have a good night, and best wishes for our work in this particular tobacco cessation field. Thank you.
Thank you very much. Have a good night.
Good night.